Our next speaker is Dr. Silberstein, who's the head of the headache program at Thomas Jefferson, and he's going to be talking about new insights in the mechanism and treatment for headache disorders with an emphasis on SAH.
I think the bottom line is we have no idea in the world why somebody gets a headache for low pressure, and the best example is why doesn't everybody get one after a spinal tap? So I'm going to talk about a number of things. What are the different pain fibers? What's going on? Could you make that work for me? Oh, here we go. Can't push the right button. What's involved in pain transmission? What role does sensitization play in pain and headache? What causes headache? What causes low CSF pressure headache? Compliance, drift. We'll talk about these things. Fibers. Just as a reminder, the A delta fibers give you sharp pain, the C fibers give you dull pain, and the A beta fibers give you a touch and vibration. And many of the new devices for the treatment of pain involve either modulation of the A delta or the A beta fibers. Acute pain, this is just a reminder. If you take and stimulate, you get your first pain from the A delta and the second pain from the C fibers, which can then be isolated. So the question really is, when you see a patient and they describe a sharp pain, it's a little bit different in generation than a patient who describes it otherwise. I think one of the concepts we need to think about in terms of chronicity is the phenomenon called sensitization, which is increased responsiveness to stimuli. Hyperalgesia means you're more responsive to the pain. Allodynia means that a non-painful stimulus is now painful. Peripheral sensitization. If you've never heard about it, you've had it. You touch your hand, it doesn't hurt. You get sunburn and touch your hand, it hurts. That's peripheral sensitization. Central sensitization is different. It means that the neurons upstream have become active, there's increased spontaneous discharge, and the receptive fields have expanded. So think about it. Why does pain persist? Could some of these patients have developed secondary sensitization? And very simply, with peripheral sensitization, inputs go into the central nervous system. There's modulation of wide dynamic range neurons, and this is a potential explanation of what could possibly be happening. So what causes headache? Traction, distension, or displacement of pain-sensitive structures, venous or venous sinus distension, inflammation of pain-sensitive structures, obstruction of pathways in primary central pain. A lot of people now are looking a lot more about inflammation. So what are the different structures? The scalp, the dura, the venous sinuses, pain-sensitive cranial nerves, and the head and neck muscle. These are the structures that are pain-sensitive. Now, what's been happening, you heard a lot about spinal fluid earlier today, and I think I had the pleasure of having breakfast or lunch with a speaker who got me totally confused about everything I ever learned. And if you think about it, you have to approach things differently. Brain waste diffuses into the spinal fluid and gets removed. And the potential sites, the arachnoid granulations, the cribriform plate, the dural lymphs. And one of the things that's very interesting is, and you heard about this earlier, I didn't know what he was talking about, the brain and spinal cord interstitial fluids are regulated with gradients of osmotic and hydrostatic forces. The Pulsatile CSF movement is created by the systolic-diastolic oscillations with blood circulation. You heard clearly earlier, it's dampened. This enables the distribution of substances throughout the brain. This I found, this is actually cerebrospinal fluid oscillations in human sleep, published in Science this here, can we get it to run? Yeah, this is a living human being sleeping, and using magnetic resonance imaging, you can actually see the pulsations of spinal fluid in a sleeping, living human being. And the way they do it is, if you know a little about imaging, the wavefront doesn't pick up the signal like the things following it, and you can look at it. So I suggest, if you're interested, read the paper. When I saw this, it nearly blew me away. The other thing that's come around lately is the entire concept of the glymphatic system. We used to say that there are no lymphatics in the brain. Maybe not. But the glymphatic system consists of tunnels that follow the piedural and cortical blood vessels in the perivascular space. And you can actually see them here and here and here. It is the body's way of giving lymphatics to the brain. And how do we know that this system removes waste? And there's actually an animation at the bottom simply showing the fact that you can actually, and this is a little study in Science Transitional Medicine, you can actually inject chemicals or markers into the substance of the brain itself. You can actually follow them being transported out of the brain. So basically, a concept is developed that during certain stages of sleep, the system is active and open. And some people have had the concept that perhaps sleep really is a housekeeping mechanism for the brain. And what affects lymphatics? You heard about aquaporin 4, pulsatility, adrenergic tone, body posture, sleep, hypnotics, spinal fluid leaks, and head trauma. It has been shown in some models. If you look at the clearance of the glymphatic system, after a spinal fluid leak, it closes down. People were talking earlier about that, and that's one of the potential mechanisms. Intracranial pressure, you've heard about that. Hypotension with pressures below 70. And I think the issue we need to think about is the spinal fluid pressure in a recumbent position, when we measure it, is probably useless to look at intracranial hypotension. You heard earlier about the different causes, and I'll skip over that. Now, why do you get a headache if your pressure is low? Well, do you lose buoyancy? Could it be traction of the dura? Intracranial volume loss can cause compensatory dilatation of intracranial structures. But here's the point. If you actually do gugular compression, it increases intracranial pressure and venous dilatation, and therefore headache cannot be done to intracranial hypertension alone. Let me say that. Squeeze the jugulars, venous pressure goes up, intracranial pressure goes up, the headache gets worse. We were talking a bit about buoyancy. Does the spinal fluid loss decrease the buoyant force? Hard to say that. We talked about the tension in the veins. And the question is going to be, if there was not spinal fluid surrounding the brain in some way at all, how could you survive? You may have heard earlier that the brain itself is heavier than the spinal fluid, but it won't change the buoyancy with a small amount of loss. We all know that the sum of the cerebrospinal fluid, brain, and intracranial volumes are constant. One goes down, the other goes up. Spinal fluid loss decreases the pressure, but not venous pressure. There's a gradient and more dilatation in the upright posture. This dilatation may engorge venous structures and cause orthostatic headache. And what's the evidence for that? This is actually PU vessels dilating as the cerebrospinal fluid decreases, clearly showing with decreasing pressure, you get reactive vasodilatation. So, for a long time, the debate existed: intracranial hypotension, intracranial hypovolemia, or neither. CSF pressure. The headache can occur with normal pressure, no correlation between pressure and headache. Jugular compression raises the pressure, the headache gets worse. Maybe volume. The concept that's coming along is we've been looking at the wrong things. It may in part be related to compliance. And you heard earlier today that part of the pulsatility of the blood vessels is managed by changing spinal fluid distribution. Let's talk about pressure volume curves and compliance. Look at the volume and the pressure. And this is the second curve, which is more compliant. The dispensability is the slope of the curve. Think about it. Increase the compliance, increase the dispensability, decrease the pressure, increases the compliance. I'll show you some examples. The compliance of the membrane, including enclosing the spinal fluid, is different. The top, you have a rigid skull, so it depends on the compressibility of the veins and vessels. The caudal or back component, it depends on the degree of filling of the spinal dural flac. If you increase the lumbar compliance, more give, it causes the hydrostatic indifferent point to be displaced caudally. What am I talking about? What is a hydrostatic indifferent point? It's the point where the upright spinal fluid pressure is equal to the pressure when the patient is lying down. Repeat. If you do a spinal tap and then sit them up, where are the 2 points the pressure are equal? The spinal fluid leak increases the lumbar compliance, you get more give. Increased lumbar compliance shifts the hydrostatic indifferent point downward, independent of a change in volume or opening pressure. Upright intracranial pressure is further decreased by the distance the hydrostatic indifferent point is decreased, and a change in lumbar compliance alone without a leak could cause orthostatic headache, and the neurosurgeons would tell you a big baggy sac can do it. And this is an example. The hydrostatic indifferent point is located along the upright axis where the spinal fluid pressure is there. So this is 150, 150, and that's the hydrostatic indifferent point. Okay, now what happens? You develop a leak. There's a hydrostatic indifferent point. You develop a leak. You get capaciousness there, increased compliance, and what happens? You get a hydrostatic indifferent point shifts down. And you get a headache. So the entire concept, it's not volume, it's not pressure, but it's the spinal fluid dynamics affecting the membrane that make a difference. Intracranial pressure is negative when standing. Now this is another interesting concept. This is actually a rather new paper. The classic spinal fluid circulation, you just heard, inside the ventricles to out, is not possible biophysically. Non-compressibility of the cranium dampens fluid volume oscillations. It enables constant blood-brain perfusion with a change in the head pressure. Without that, a giraffe could not stand up. The cerebral perfusion pressure values in an upright posture are clearly greater than previously believed because of this compensatory system. And this is a concept, the diagram, if you're interested. Again, a lot of people use these biophysical examples. In this particular case, they use a tube sealed in one end. And the concept that a plastic tube filled with fluid open the lower end really mimics what happens in the cranium. And what you can see is the transfer occurs between the bottom of the tube and the cecal sac. And you heard about earlier that the pulsations of the blood vessels are dampened by sending fluid lower. Now, what happens with a spinal fluid leak? It increases the caudal compliance of the spinal space relative to the top. The HIP is downward. Intracranial pressure is more negative, equivalent to the amount of the displacement. That's decreased in addition to the loss of filling pressure. Let me say that again. The normal pressure, say for the sake of argument, is 15. You have a leak, you measured, it's 10. But it's more than that when you sit up because of the decrease in the hydrostatic indifferent point. Cranial compliance decreases with spinal fluid leak. The veins are normally slightly collapsed, but because of that, the CSF pressure exceeds the dural sinus pressure, and you get venous engorgement. The walls become stiffer and less compressible. That is why, in the head, the compliance decreases. Now, the lumbar dura usually resists stretch. It limits the distensibility of the caudal space. Large holes increase the compliance by allowing the area outside there to expand. And more important, if you lower the pressure, you get more. It's like a balloon. You blow a balloon up, it doesn't move much. You let air out, it's more compliant. When you take away spinal fluid, it's like letting air out of a balloon. Now, how about a spinal fluid leak with normal recumbent pressure? Increased lumbar compliance can occur with normal filling pressure and volume, but there is an abnormally low sitting lumbar pressure. You still get caudal displacement of the hydrostatic indifferent point. The erect intracranial pressure is more negative, and the erect lumbar pressure is more positive. Now, why don't you get a headache or a problem with a cranial spinal fluid leak? Often there's no headache. When you get a cranial leak, you get increased cranial compliance. It causes the hydrostatic indifferent point to go upward. Decreased filling pressure increases the compliance. And basically, they balance each other out, and there may be not a big enough change of the hydrostatic indifferent point to go down. And that's one of the reasons you do not get a headache in the presence of a spinal fluid leak above the head. Now, let's talk about lumbar puncture headache. A lumbar puncture causes caudal displacement of the hydrostatic indifferent point. So let me give you some examples. You do a spinal tap. The pressure is 18 lying down, 53 sitting, and the hydrostatic indifferent point is 35. You then have a post-LP. The pressure is now 5.5, 28 sitting, and the HIP is now 22. It's really a 12.5 centimeter change, which is a result in the decreased pressure intracranially. Intracranial pressure decreases, 12.5 recumbent, but 25 centimeters upright. Standing produces a marked increase in transmural venous pressure. The intracranial pressures dilate acutely, more distension due to loss of filling pressure, and it could be that the acute orthostatic venous distension causes the orthostatic headache in part. Again, the hydrostatic indifferent point, just to reiterate. It's a new concept. It took me a while to learn this. Lying down, sitting up. What happens? Normal. Increased compliance. The hydrostatic indifferent point comes down, and one develops a headache. So the way to look at this is a series of balloons. You got a balloon here, and a balloon there. By reducing the pressure, the balloons are more expandable, and when you stand up, more spinal fluid drifts down, and the pressure decreases in the head. Now, the other point is that there are different compartments of the spinal fluid. Cervical subarachnoid space, this is from the lumbar. There's not as much room to expand. The caudal displacement, the hydrostatic indifferent point, is closer to the head than it is to the tail. The compliance decreases but does not overcome the change from filling pressure. So that's in many reasons why, just like with intracranial leak, you do not get a headache with a cervical leak. Standing, spinal fluid goes from the cervical and intracranial compartments into the more compliant lumbar sac. Cervical dura partially collapses with compensatory acute distension of the cervical epidural veins. That may account for the neck pain in patients with leaks. Intracranial vessels dilate, causing orthostatic headache. Young children, older adults, are stiffer. They have less change in caudal space, and they may have less headache. I remember in the old days of doing pneumoencephalograms of older people, they didn't get a headache afterwards. So I believe that concept. So what can we conclude? Intracranial hypotension, it may be caused by an abnormal distribution of cranial spinal elasticity. Increased lumbar compliance causes the hydrostatic indifferent point to move down, more intracranial hypotension and venous dilatation and the erect posture. It can explain the orthostatic nature of the headache, the fact that spinal, not cranial leakage, produces a headache, the imperfect correlation between pressure and headache when you do it in the lateral decubitus position, and near absence in the very young and the elderly. Last but not least, it has been shown that if you look at the glymphatic system, if you create a spinal fluid leak, it closes down. The glymphatic system is responsible for removing waste, and if you don't get enough sleep, it's basically because your glymphatic system is blocked up and you're cognitively impaired, and this may in part explain some of the other things we see with spinal fluid leaks. Thank you.